Welcome everyone to today's webinar. I am Brian Zimmerman, Custom Content Editor for Becker's Healthcare. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Abigail Obongwa is Vice President of Revenue Cycle for the University of Wisconsin Health System. She is responsible for the overall strategy, operations, and optimization of the revenue cycle across UW Health. This includes oversight of pre-service financial clearance, registration and technical services, financial counseling and provision of charity, charge capture, coding and clinical documentation improvement, health information management and transcription, billing to third parties, and patient financial services. Abby leads decisions around the necessary resources, systems, tools, processes, and investments to fully realize revenue associated with patient services and coordinates these services with all of UW Health partners. Prior to joining UW Health, Abby served for over 20 years in various leadership roles at Wheaton Franciscan Healthcare in Southeast Wisconsin. Rochelle Buell is the Director of Coding and CDI at UW Health. She oversees all hospital coding and clinical documentation integrity functions. Rochelle's primary responsibility is to ensure compliant coding, accurate charging, and documentation education. She has worked at UW for over 17 years and in the HIM field for more than 21 years. Rochelle's experience also includes serving as the Director of Coding at Fordham Health and a variety of positions in coding and health information management. Denise Tinkle is a Director with Prism Healthcare Partners, a national healthcare consulting firm. Her extensive background in healthcare quality and clinical documentation improvement includes 2 decades of experience providing bedside patient care to critically ill patients. At Prism, Denise partners with hospitals and health systems across the country to leverage outcome data to develop policies and procedures, mentor and train physicians and other healthcare professionals to understand quality performance measures and improve quality outcomes through clinical documentation improvement. Annie Gohl is a manager with Prism Healthcare Partners. She specializes in revenue cycle collaboration and consolidation across multi-facility health systems. Annie has helped a range of healthcare providers increase net revenues through identifying and implementing process improvements in areas including insurance verification, pre-registration, point of service collections, billing, insurance collections, customer service, cash posting, vendor management, denials management, and Veterans Affairs. At this time, I'd like to turn it over to Abby, who's going to tell you a bit more about our webinar goals today and a little bit more about UW Health. Abby, take it away.
Hi, good afternoon, everyone. Welcome to this webinar. We're very excited to have some time this afternoon to share some of the really good work that we've done here at UW Health in partnership with Prism Healthcare. And so what I'll do is provide just a brief outline of our time here today, and then we'll turn it over at some point to the panelists to share what you're really here for. We'll start by talking about what our key focus areas were. There were 3 areas within the middle cycle of the revenue cycle that we focused on. We would like to share our learnings in terms of the importance of collaborating with our partners within our own teams, but also our partners outside of our teams as we work on process improvement and on identified opportunities for cost reduction or revenue enhancement. We will share some information on data, metrics that we use to most importantly establish baseline for ourselves as we started our work, and also that we use to measure our progress, and also that with Prism having left us now, that we're continuing to use to ensure that we sustain the success that we gained. Importantly also is who was involved in this project. We can't always do it ourselves, so what team members were involved from across the revenue cycle and oftentimes outside of the revenue cycle as well, and how we worked with those team members to achieve buy-in at all the right levels. We'll talk about how we implemented strategies and tactics that we use now to maintain the improvements gained. And we want to leave you with some food for thought around pitfalls to avoid as you embark on your own efforts. Next slide. I also wanted to give you a brief overview of who UW Health is. UW Health is a $3 billion integrated health system of the University of Wisconsin in Madison. We serve as the teaching institution for the UW School of Medicine and Public Health, and we partner with the school to fulfill our missions of patient care, research, education, and community service. We also own a health plan called Quartz Health Solutions, which is the second largest health insurer in Wisconsin. We cover about 338,000 lives who live in Wisconsin, Illinois, Minnesota, and Iowa. In our most recent fiscal year, we served more than 630,000 patients from the upper Midwest and beyond. Our system employs a little over 1,750 physicians and almost 21,000 staff members. We have currently 87 outpatient clinics and 7 hospitals, 5 of which are in Madison, Wisconsin, and 2 in Illinois. We're an institution with a proud heritage, and we have numerous accolades that we've received over the years for our great work, and I wanted to highlight a few of them. If you look on your screen, these will be highlighted in the top right-hand side of the screen. We've been named by U.S. News and World Report's America's Best Hospitals in the top 50 in 9 medical specialties. Our children's hospital was also ranked among the top 50 children's hospitals in the same report. We've enjoyed being named top hospital in Wisconsin for 6 years in a row. And this year, our transplant program actually celebrated its 50th year and has been recognized as the 4th largest transplant center by volume in the United States. We're Magnet recognized, and last but not least, we've also received 10 years in a row National Research Corporation's Consumer Choice Award for Best Doctors, Nurses, Overall Quality, Image, and Reputation. So we come from an organization that has done some wonderful work, and we're very proud to be here and to share with you. Next slide.
Thank you, Abby. Really appreciate you setting the stage there. So now I'll put this question to you. What is the middle revenue cycle?
Okay, so the slide in front of you, I believe most of the individuals on the phone are either revenue cycle leaders in the middle cycle part of the revenue cycle or finance leadership. So I think we all know what the revenue cycle is from front to back. But for our purposes, when we began our work with PRISM, we defined the middle cycle of the revenue cycle as all of the work we do from a charge entry perspective. These would be your automated processes or charge entry that happens by physicians when they do their documentation or by coders or other individuals on our teams. Case management and utilization review, that the work we do partnering with those teams in terms of ensuring that patients are appropriately in the hospital and that we're doing our work timely to ensure that patients transition to wherever the right setting is post-discharge. Documentation and coding, so all of the work we do with our clinical documentation specialists concurrently while the patient is in-house, as well as the work that the coders do post-discharge to ensure that the appropriate service provided to the patient is captured so we can bill appropriately. And last but not least, HIM and transcription is also part of what we would consider the middle cycle. However, for purposes of today's presentations, we will be focusing our conversation on work that was done in the clinical documentation space in our coding area, as well as some charge entry related activities that we had worked on. Next slide.
Thank you, Abby. So yeah, we're going to cover charge entry and clinical documentation. So I'd like to put this question to some of you today. What was unique about UW Health's approach to middle revenue cycle improvements? I think, Rochelle, we can start with you.
Hi, this is Rochelle Buell from UW Health, and just want to thank everybody for joining us today and hearing about our exciting adventure with PRISM. Our initiative was different in that we had one vision, one goal under one leader, and that was me. Some of our initiatives and goals for fiscal year 2018 was to develop a collaborative coding model between my CDI and inpatient coding team. We are also striving to reduce our coding AR days by improving efficiencies in coding workflows and increasing productivity. Engaging with PRISM in the fourth quarter of 2017 was our ticket to help get all of this done. This resulted in my team having 3 major projects going on at once. The leadership team in CDI, inpatient coding, outpatient coding supported each project, engaged in the changes coming, and communicated frequently with staff to ensure we met our deadlines. This was key to getting a lot of work done in a very short amount of time. In addition to my team being very engaged and excited, we also had momentum from the top of our organization, reiterating that we were all responsible for supporting these key initiatives. Over to you, Annie.
Thanks, Rochelle. From a PRISM standpoint, UW had processes in place already. We were really looking to help them enhance what they had and achieve their goals. From the start, we knew how closely related the initiatives would become due to the structure of the department having CDI, hospital coding, and professional coding under one umbrella, and Rochelle being that overarching leader. Many of her leaders were involved across the initiatives that we were conducting, so workflows and communication between the teams were also prevalent or needed, so we made sure that our initiative teams were communicating on a weekly basis to ensure that we knew what each other was doing and were able to collaborate when appropriate. Next slide.
Thank you both for those insights. And so can we talk a little bit more about what were the key areas UW focused on within the middle revenue cycle? Abby, we can move back to you.
Thank you, Ryan. All right, I will give a really brief overview, and then I'll pass it on to the subject matter experts, Rochelle, Annie, and Denise, to give you more details. So the first area we talked about, that we worked on, was optimizing our inpatient CDI program. So Rochelle will talk about the fact that we already had a program in place. We've been ramping up, but there was a lot of additional work that we did with PRISM. So we'll share what we did to kind of enhance the program and get additional value. And we'll talk about a really important component of this work, which was the collaboration that we designed between the CDI team and the inpatient coding team, which has resulted in a lot of efficiencies gained in our program. We're also going to talk about work done to reduce our cost to code, specifically focusing on the vendor management piece of it in terms of reducing our vendor spend, and also some other internal process improvements, working with our inpatient coding teams and outpatient coding teams as well to improve their efficiencies. And last but not least, we'll spend some time talking about our outpatient documentation and charge capture efforts, specifically related to 3 areas. We had work done with our ED. We also had some work done with regards to our infusion start and stop times by leveraging our Epic technology, and also some work regarding interventional procedures. And with this, I'll turn it over to Rochelle to dig into the details.
Okay, our main goals with the CDI project was to enhance our existing CDI program and establish collaboration between CDI and inpatient coding. Next slide. So the history of CDI at UW Health started in 2010 with 4 people. We had 1 coder and 3 nurses. In late 2016, we requested and received approval to hire 11 FTE to provide additional coverage for our hospital. When PRISM began working with us late in 2017, we had made huge progress in training new staff and establishing a more robust CDI program. While we were growing, our mission vision never changed since 2010, to review the documentation and ensure completeness of record, which includes SOI, ROM, diagnosis, and procedure capture, and last but not least, clinical validation queries. Next slide, and over to you, Denise.
Thank you, Rochelle. CDI education was very important at UW. As Rochelle said, they had hired several more team members, so there were differing levels of knowledge within the team. Classroom education consisted of 16 sessions over a period of 4 weeks. We worked with the CDI team to allow them to still have productivity in their day, so our sessions were limited to 2 hours each day. Topics that we covered in education included diagnosis and procedure coding, principal diagnosis assignment, clinical view of the medical record versus coding view of the medical record, and query writing. A major focus on queries here was consistency in how those queries were written. Standardizing queries provides more organized information for the physicians, as well as guaranteeing compliance with non-leading queries. We also did classroom education with the coders. We invited all the coders and coding leadership to attend the intensive classroom training. We found that having coders attend the CDI education is essential to that collaboration that Rochelle and Abby both talked about. One of the advantages of having the coders attend the CDI education is that both groups hear the same information at the same time. The classroom sessions were interactive, with both the coders and the CDI team posing questions and discussing clinical and coding topics. For side-by-side review of medical records, one-on-one clinical mentoring started at the same time as the classroom education and continued for several months after that. Brian, please go to the next slide. On this slide, you'll see just an example of teaching materials that were used at UW. All of those education materials were left behind for the CDI team to use as reference. Rochelle, back to you.
In order to absorb the recommended process and workflows, we had to do a staffing analysis to ensure that we had adequate coverage. We now have, in our current program, 17 CDI staff, and they are made up of by 3 coders and 14 nurses. We have 1 QA, or quality analyst, 1 supervisor, and 1 manager. Adding additional staff led to the following coverage rates. So one of the reasons that we had added the original staff to begin with was because we were only providing about 25 to 30% coverage, and that was in 2016. When we ramped up and added additional staff, and while doing the training with PRISM, we covered about 70% of our admissions. And finally, in 2019, now that PRISM has left and most of our staff are adequately trained, we are at about an 85% coverage rate. Our query response rate pre and post remained pretty stable during this time as well, between 97 and 98%, and did not decrease during our PRISM training. Next slide. For the first couple of months, we were heavily involved with the training, the CDI and coding staff on the CDI principles. Once that baseline education was established, to the extent that folks were productive and knowledgeable, we began our collaborative meetings. We were very calculated about the timing of these meetings and how we would bring everyone together. And here are a few examples of what we did to make this easier on our staff. They may not have felt it, but it was easier for us in management to ensure that we were getting the end results we were looking for. First thing we did was assign seats for every single meeting that folks came on site for. This allowed people to get to know different people within the groups. We ensured that the first part of the meeting was fun with icebreaker type activities and definitely had food to develop those personal relationships. Meetings were mandatory and on site. Since most of our coders have worked from home for years, they had had no interaction, at least face-to-face, with some of the CDI staff that had been on board since 2010. So once we established this baseline trust, we moved into deeper discussions about common queries and DRG mismatches. Some that were particularly lively for our groups were sepsis and encephalopathy. To ensure the momentum moved forward, we created internal guidelines to ensure that the decisions set forth in those meetings were adhered to in the future. We also held physician-led topics with a top neurosurgeon that talked to both groups about brain compression and cerebral edema, because coders and CDI appreciate the clinical perspectives that come from a provider's presentation. Next slide. One thing that my leadership team was very passionate about was to ensure that any discussion where we had differences in coding or CDI expectations that we formed a joint policy for the teams. Our first policy outlined the difference between what was a clinical query that was sent by the CDI and a coding query that is sent by a coder. The second policy is to give guidance to the coders on what constitutes querying when the discharge summary is less than helpful. Most of you on the line can definitely feel what I'm talking about when it comes to discharge summaries and not always having adequate information. I'll give you an example. When a definitive diagnosis has been established in the medical record documentation and a symptom of that diagnosis is in the discharge summary, the diagnosis overrides the symptoms. While this may seem like a no-brainer, there are diagnoses that make coders very squeamish. Sepsis, pneumonia, or acute respiratory failure with hypoxia, and they definitely want to be 100% certain before coding these, which led to us potentially querying additionally after discharge. Denise already talked about the job shadowing, but we did this for several hours to really gain that true understanding of each job. Knowledge sharing and job stressors definitely elevated the bonds to take them to the next level, which we purposefully waited until later on in this transition was the reconciliation training. Reconciliation training was left for last because it can be somewhat difficult when you have strong beliefs on either side of the fence. Developing that personal relationship, trust, and understanding were pivotal to ensuring this process went smoothly. Our current model, the coders are still not directly involved in the reconciliation process. We actually have that going through our leadership teams and then information shared later on. There may be a time in the future that we will get to this, but certainly not right now. Next slide. So the work that the team did, both teams showed some very, very positive results. From the time that PRISM came in to the time that they left, we had increased our productivity by about a half a chart per hour, 0.5 chart per hour. We had decreased our inpatient queries that were being sent after discharge by 70%. This is attributed to a major decrease in our AR days, because when I looked at our statistics yesterday, 2/6 of 2019, compared to 2/6 of 2018, we had decreased this year by $14 million just in the inpatient side. So some really nice work that was done by the teams to ensure that we were being productive and efficient at the same time. Brian, if you could advance to the next slide. I wanted to give you a brief overview of some ClickView dashboards that we created during the time that PRISM was working with us. This is just a snapshot of a few things that we have embedded within our dashboard. The CDI, this outlined our baseline and definitely helped with our progress to help identify areas of opportunity, but it also is a way for us to show quick wins to providers and staff. So some of the items that we track on ClickView are severity of illness and risk of mortality, which through this exercise have been an amazing improvement. We're really proud of the quality scores that we're seeing from our activities. We can drill down by provider, department, or service line for metrics on response rates. Because we are an academic medical center, we have chairs and vice chairs that are interested in their department, but they also might be looking at the service line itself, which could be very different and might be more specialized, especially when you get to areas like surgery, who would have a breakdown of all of their different service lines. We can run it by types of queries, so we can get those top queries, which you'll see on the right-hand side of the slide. We, of course, track and monitor case mix index, and every single one of our coders' productivity and query metrics are all embedded within this ClickView dashboard. I attribute the success of this to my manager, who did a fabulous job on this dashboard. It's definitely been worth the pain and efforts that he put into developing it. Over to you, Denise.
Thank you. There are many critical success factors in CDI, and as Abby said, pitfalls to watch out for so that we don't lose momentum in our performance. Some of these success factors include physician engagement, that collaboration that Rochelle and her team worked so hard to establish, and engaged CDI and coding leadership. One of the things too is we need to continue to dig deep in those records as we're looking at them. You saw the list of the most common queries that are placed, and we need to always make sure that we are looking for every opportunity to improve physician clinical documentation for an accurate and complete medical record. One of the success factors that not all programs have in place is that physician champion. We strongly recommend that a CDI physician champion is engaged with every CDI program. This role will help facilitate conversations with those docs who are not fully participative with your CDI program. And it's also helpful if you have a query escalation process for resolution of queries that are not responded to. Another critical piece is engaged leadership. It's not so much about the reporting structure. Instead, it's about the day-to-day involvement in the CDI program, understanding its operations and the importance of the program itself, and then the value that it brings to the organization. Handing it back to you, Rochelle.
Thanks, Denise. One question that we heard on the line was, what is CDI? And I apologize, we tend to talk in our own languages here. CDI is Clinical Documentation Integrity. I've also heard it improvement. I think it's dependent on the day. Sometimes it's dependent on the model. We like to refer to it as integrity, as it speaks volumes to our motto, which is completeness of the medical record. That'll wrap it up for our CDI portion of the presentation. I'm going to take us into the next slide, reducing your cost to code, and we're going to talk through our vendor management review and some internal process improvements that we did with this project. Next slide. Our first step was to renegotiate our current vendors' rates and terms. So we began our process reviewing our coding outsourcing and auditing contracts that had been in place for a very long time. This is especially important post ICD-10, where the cost of outsourcing went up significantly. In addition to the rates, we looked at the structure of the contract with respect to the terms and conditions. For instance, when we signed on a coder with one of our contracts, we had to contract that person for 6 months and would pay regardless if they had work or not. Our goal was also to reduce hourly rates and gain more flexibility with our current contracts or obtain new contracts. In this process of the review, we were able to decrease our hourly rate for coding outsourcing by $15 per hour, and we were also able to increase our charts audited while cutting our monthly costs for auditing by 50%. Both of these were very important, and this review was pivotal to our success because it not only allowed us to negotiate some better rates, but we were also able to build in some more flexibility with additional contracts where we didn't want to move away from the current contract we had because we valued them as a partner, but we needed a little bit more flexibility just in case. Next slide, and over to you, Annie.
Rochelle, can you go ahead and go over the internal process review?
Yeah, I will. Okay. In order to set performance expectations, what we needed to do was identify some barriers the coders had while coding the records. So this was our internal process. This was a way for us to identify any of the issues that we might be seeing with the coders. We started out by having several staff being shadowed by PRISM, and what we allowed them to do was share their frustrations of the workflow and also to field their questions like, why do I have to do this? Or why is this provider always documenting this way? After the review of several coders, we put all of the issues into a spreadsheet and identified owners for the task. We reviewed the list on a regular basis and identified a few wins for the team. So when we did that, we assigned the managers and our leadership team to follow up, assign the task, work with our IT counterparts, work with different departments to ensure that we were tackling all of this. Some examples of quick wins that we had were abstracting the date of death was being done on the inpatient side. We actually found out this was being done by another department, and we no longer had to abstract and look for that because that is something that isn't inherently visible to everyone and sometimes takes a little bit of digging. So that was a win. The discharge disposition for inpatient, we spent hours, scouring the record, trying to find and make sure we had the appropriate disposition for inpatient. And it is not that we don't do that today, but we also found out that we have a report that captures discharge dispositions that error out, and then we can go in and fix those. Because sometimes at the time of discharge, we only know what we know that's in the medical record, and what happens once they leave the doors of the hospital could be something completely different. We were also stopping accounts and holding them in coding to have things like the ADT fields or the class or attending issues. We had dug deep into these and designed workflows to enable the front end to resolve these before it even got to coding. We also increased our simple visit coding, which we are still working on tweaking and ensuring that we have a very successful model on this. The results were an increase in productivity, minimally. I would say that it didn't go up by a huge amount, but there were definite wins in that. There was an increase in staff morale, if you can believe it, with some of these major changes. And I want to say that it was due to an advisory council that we had set up on the facility side a couple years prior. And this advisory council has identified line level staff. So we have line staff that sit on this committee, and they're the voice of the teams and our management. There are no managers on the team, and issues that are brought forward by different team members to the committee remain anonymous. The managers take things like our policies or workflow changes to this committee and help them with feedback to the staff if it is something that is going to be a major change. This model has been really successful for us, and we're really proud of all of the work that the team has been doing. Next slide, and over to you, Annie.
Thanks, Rochelle. So in addition to vendor management and the removal of barriers, the coding leadership worked together to update their performance expectations. As a part of our work, we conducted a staffing analysis for both hospital and professional coding. I'll get into the other data elements on an upcoming slide, but one of the major elements that was needed was to reset the standards for each type of work. At UW, this was either by patient type or by work type, such as claim edits or denials. Rochelle, can you go into a little bit detail of how the standards were set and rolled out to the staff members?
Yep. So once we eliminated some of the barriers and our productivity had increased, we looked to set the standards. We wanted them obtainable, but we also wanted to stretch them a little bit so that it wasn't just easy peasy for them to meet the metrics. When we revised the policy, we had our advisory council review it and give us feedback because we wanted to ensure that the timing that we were rolling it out was okay, and that we were giving enough time to the team to really absorb when this would go into effect. Our advisory council recommended that we roll this out approximately 4 months, and they were in agreement, management was in agreement prior to our go live. This allowed our management team to give feedback and have conversations with the staff about any areas that they could improve upon. The increase in productivity decreased our reliance on outsourced coding by over 50%. Back to you, Annie.
The coding department had performance trackers and scorecards when we started our work. However, they were not consistent for all teams within the coding department. We decided on a consistent approach of tracking, which leadership could view by team, and scorecards that showed key performance statistics and metrics. That way, coders would know how they were performing individually by the week and by the month compared to the goals that have been set and compared to the goals of their team. So if we could advance to the next slide, I'll show you an example. So here we have an example of the monthly performance scorecard that we created. As you can see, our coder here, Bucky Badger, he can see his personal performance versus the team and the goals set for individuals on his team. We also provided free text forms for the leadership and for team members to input their comments. If you can go back to the previous slide, please. So as a result, to establishing consistent performance expectations and through sharing and monitoring individual and team performance, production increases were seen for all hospital coding teams. And this actually included their vendors as well, because the same standards were set for them too. With the improved production, internal staff were able to increase the volumes they worked, and Rochelle was able to decrease the number of vendor resources that she needed for her coding work. Okay, if we can go to slide 25, thank you. At the start of our work at UW Health, our PRISM team worked with leadership to form a position control committee. This was organization-wide, and any staffing changes were submitted to this committee. So in order to meet the needs of the coding department and that committee, we completed staffing analyses for hospital and professional coding. For hospital coding, we did both an inpatient and outpatient model, and then by each academic department for the professional analysis. So for the professional analysis, we created an overall summary which rolled up each of the departments that allowed us to view the 17 departments both at the individual level and holistically. We also used the same data elements for each analysis. We used yearly patient volumes, which we received from the UW Enterprise Analytics team. We used the productivity standards that Rochelle mentioned earlier that we updated, and then we used a yearly production percentage. This actually accounted for things like PTO, team meetings, continuing education, and other non-productive time, appropriate non-productive time during the year. Once this data was complete, Rochelle and her teams were able to determine how to utilize their staffing resources in an optimal manner. So Rochelle, can you go into a little bit more on how you utilize those resources?
Yep. So the staffing analysis led to more conversations between the professional and technical coding teams. When backlogs were identified, we looked at all of the teams to see if there was an area that we could have help or offer to help. One example of this is when we utilized an ED facility coder to help with professional coding backlog in the ED after being trained. So it was an opportunity for us to set up these conversations and only replacing the staff when it was really deemed necessary based on the metrics and the data provided. Overall, this resulted in labor cost savings. Next slide.
So when looking at the work done to reduce the cost to code, there are factors that will aid in your success and common areas to be aware of. When it comes to selecting vendors, even if you are satisfied with your current vendors, still take the time to periodically check the rates and terms to make sure that you are getting fair and competitive rates. Utilize your team members that are doing the work to share what their barriers are. So no one knows better than they do of what is limiting them from being as productive as they can be. So be sure to give them a voice. And then as a leadership team, let them know what you're doing to fix the barriers that they bring up. Team members can't be expected to meet performance standards if they don't know what they are or how they're doing. So be sure to clearly document expectations and then hold them accountable by routinely sharing the information and coaching them as needed. And just because there is a vacancy or a backlog, it doesn't necessarily mean that a position should be filled or more resources are necessarily needed. The data from a staffing analysis can provide insight to where internal shifts can be made either on a permanent or a temporary basis. The use of the data will also help drive conversations with leadership or position control committees. So having such committees and asking, do we really need to fill this vacancy, can result in labor savings for both your department and for your overall organization. Brian, if you can go ahead and advance the slide, and Rochelle will move into the next topic.
Thanks, Annie. Our third and final topic is implementing outpatient CDI documentation charge capture in these three areas. We are going to discuss them further. So, Brian, if you could advance to 28. Our first area that we looked at was the emergency department. We did a comprehensive review of facility documentation and what was performed to identify where we had education, assessments, and monitoring taking place, but there was not adequate documentation in their medical records. It was identified that the patient acuity was not necessarily reflected in the notes written by the nursing staff. As part of our project, a key component of this was working with operations and administration in the ED, or emergency department, to identify gaps in the documentation. We performed deep dives into critical care, trauma activation, reviewing orders for supplies like isolation, DME, and with these reviews of orders, we were then driving checks and balances in the system so that if one was placed, that we were analyzing and looking at that to ensure that a charge was also dropped. Very successful project. I would say that the key takeaways were definitely have your administration ED operations on board. We leveraged and weighed on them heavily in order to make some of these changes with the nursing staff. Our second project was the Interventional Radiology and Vascular Project, and this was to review some missed charges for IR and cardiothoracic. We found that some of our cases missed the primary procedure charge and also identified that one C code in particular, which is a comprehensive code for facility billing, was not correctly mapped in the CDM. The key stakeholders in this project were professional and technical coding, charge master, clinic operations for cardiac cath. And the reason we needed all of those folks was that we were going to put in several revenue guardian checks for devices and one for those add-on procedures that did not have a primary procedure. We reviewed and also updated the paper charge form that was used by our cardiac cath lab to ensure some accuracy in picking charges. Both professional and facility side code this area, but the charge is dropped by the techs. In addition, the professional coders are now alerting the facility coders when an inpatient procedure is missed or incorrectly charged. This ensures that we have correct coding in our charges for an inpatient stay because we do not code CPT on the hospital side for an inpatient stay. We are only coding the procedure codes from ICD-10. Our third and final project was on OBS OSS and infusion heart stops. So UW Health had maintained a handwritten form to capture infusion stop times on OBS OSS patients since before our Epic go live in 2009. I'll leave you with a funny that I actually created this form back in 2005, and I could not get rid of it. It took me this initiative to finally get rid of it in 2018. We were looking to have some Epic foundation build to ensure that our infusions had a hard stop. We're a very customized Epic shop with limited foundation build because we were an early adopter. So we did have some customized builds for these infusion stop times, but nothing that really stopped the staff from putting in a stop time. Our future pump integration technology supported the workflow that we were trying to implement. So the initiative was welcomed by a diverse team of pharmacy, IT, coding, CDM, and nursing informatics because they would have had to do this work regardless for their go live of pump integration later in 2019. The team was able to create the functionality in Epic and eliminate the form. This allowed coding AR days to reduce and productivity to be more efficient because the wait for that handwritten form was over. We leveraged Epic auto functionality when the lines are linked and charges can drop automatically, and the illegibility of the documentation was no longer an issue. Next slide. The success factors and common pitfalls for these projects are, I would call them pretty basic when you're going through any change in your organization. Having that engagement and key stakeholders to help you drive the change is so important that all of you are aware of on this call. We tried to highlight some positive things and helping the end users understand this is being done with an eye towards future enhancements. So helping folks understand that, yes, we're building it for now, but there's an important component that happens later on, maybe next year, the year after, that we need to make sure that we embrace that future build and understand what the impact will be. Overall, I think these three, they feel a little bit smaller in size than the other two that we talked about, but definitely has been a great experience for me project leading them and understanding, you know, what is the right thing to do for our organization. Now over to you, Abby.
Next slide. All right. Next slide. Okay, well, thank you, Rochelle, Annie, and Denise for the wonderful job sharing all of the things that we've accomplished together in the last year. I just want to take a minute or two to kind of close us out with what's next for UW Health. As we all know on the phone, the healthcare environment is ever changing. We have new challenges every day, and the minute you think you've, gotten your act together in one area, there's something else that comes up. So it's a nice thing for us, but it's also part of our challenge in leading and managing our areas. The first thing I'll say is that it's easy to get all this kind of work done and get these successes when you have the success of consultants in-house. One of the things that I had really focused on at the beginning of our initiative when PRISM came was sustainability of whatever it is we do once they leave. So whatever we were building, whatever changes, whatever operational models we were implementing, it was important that when they were no longer here, that our teams could pick up and be accountable for moving those forward. And so we're just continuing to do that right now. On the slide, you'll see that we're continuing our weekly status reports on all of these initiatives, and we're monitoring our results monthly and reporting on them. As a system, we've also built a results management office. It's still being built right now, whose role will be to work with us as operational leaders to ensure accountability for these results going forward, to ensure we don't get complacent and slip backwards. So at the time when UW Health engaged PRISM, we had probably one of our toughest financial years as a system, and we saw a turnaround. And as you know, the natural instinct when things look better is that we just kind of think back to our normal ways of doing things. Well, we can't afford to do that in healthcare. And so we will continue reporting on these initiatives and continue to find new initiatives to work on as we go forward. Rochelle and her team are also going to continue working to enhance our outpatient clinical documentation efforts, working with our population health teams and our ambulatory team leadership. Rochelle talked a little bit about the work we did with simple visit coding and the value that that brought. We have a ways to go yet in adopting much more simple visit coding in our organization, so that's another priority that we're continuing to work on and look at. And last but not least, I know this webinar focused on the middle cycle of the revenue cycle, but when PRISM came, we worked on all parts of the revenue cycle. So we continue our front-end operating model redesign, our point-of-service collection efforts. We have denial avoidance efforts underway, vendor management program. And last but not least, we're also partnering with our ambulatory team as we work to build a new Eastside facility in the next couple of years on our digital strategy for the new campus, as well as digital strategy to help us with our existing operations at our other facilities. We recognize that a lot of the work we do today is very manual, and there's technology that can help us remove some of that manual work that our staff do that sometimes is repetitive. And so that's a huge focus of our organizations as well in the next year. And with that, I'll turn it back over to you, Brian.
Thank you, Abby, Rochelle, Denise, and Annie for that fantastic presentation. We're now going to begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to get through as many questions as we have time for. We got one here. Rochelle, I think this would be a good one for you to take. So did your team leverage computer-assisted coding technologies?
Actually, we do not have computer-assisted coding here at UW. It is something that we are looking to install in the next couple of years. We have a fairly large project going on right now with standardizing our inpatient progress notes and HMPs, and that work needs to be completed before we look towards a computer-assisted coding model.
Great. Thank you, Rochelle. We got one more here that I think you could take. So can you elaborate on the quick win with discharge dispositions?
Our coders were really digging and digging in the medical record. I mean, scouring it for changes that might have been in the record from the case managers and then the discharge planners. And they spent so much time trying to make sure that that discharge disposition was accurate. And we did not know about this other report that was run by our finance department, where it would tell you if you had a patient that was discharged and then they either went to home health or they did not have home health, that you would have to change your discharge disposition. So this report has allowed us to go back and make changes, but it also, we started working with the front end with case management and talking with them about where their documentation is located for the discharge disposition to see if we can get some one-stop shopping for our coders instead of hunting and pecking all over the chart, because it's really onerous for them to look for that information that could potentially change the minute they walk out of the door.
Great, thank you so much. We've got some great questions coming in here. We'll roll with this one next. So what was your coding AR days before the changes and after? Is it gross or net AR days? Abby, I think this would be a great one for you to take.
Our AR days in our system would be gross, or actually I should say mixed. We don't net everything until on the back end. And I believe we're at 1 point.
We're about 1.9
today. And when I should say when I started here 2 years ago, which was right about the time when we started our conversations about engaging PRISM, our AR days were over 5. So significant improvement.
Thank you so much, Abby. Got some more questions coming in. Let's go with this one. So what types of barriers did you see in improving coding productivity? Annie, I'll turn that one over to you.
So as Rochelle mentioned, there were a couple items that we were seeing that coders were questioning why they still needed to fill out. I think a date of death, was that right, Rochelle? Was one of the ones that they mentioned. So we really went through a full interview process with them to see what kind of barriers that they said that they were mentioning. Some talked about system slowness, some talked about other things within the forms that they were doing. So we really went through that list and made sure that we were able to do something that would speed up the process for them.
Rochelle,
anything to add?
Annie? Yeah, I'll add one thing, and it's something that I just thought of. But through that interview process, we found that not every coder does things the same way, so with the same workflow. And we found some efficiencies when we looked at, say, our super users and then shared that information and actually did multiple training events with all of our different coding specialties. So our, ED coders who are senior complex coders that code procedures on the outpatient side, and then our inpatient. And we actually did sharing sessions of what good workflows look like to minimize some of those extra clicks or extra looks. And, it's something that after you go live with Epic, everybody should be following the same pathway, but, that doesn't always happen.
Thank you so much for the clarification there. And here's our next question. Abby, I think this would be a great one for you. So how do you feel about outsourcing portions of the revenue cycle operations versus building or improving your internal systems?
I'm a believer that with a healthcare environment as complex as it is today, it is very difficult to be the best at all of the different things that we need to do to have an efficient revenue cycle. And there are some wonderful vendors out there that have created niches for themselves and do a wonderful job. So we continue here at UW Health to explore partnerships with different vendors. One of the things that is very important for us, however, is the integration of that vendor's workflows and systems into the workflows that we use with our patient accounting system, and we're Epic Shop. No surprise, we're in Madison. And so absolutely open to it. I don't know that my thought process right now is in support of full outsourcing, because there's some really wonderful work that our team does here, and in some cases does better than some of the vendors that we've actually explored. But I think being open to using vendors as it makes sense in the right areas is absolutely something we all need to be open to in an era where we have to continuously find ways to reduce our costs.
Thank you, Abby. Appreciate that candid response. And it looks like we have time for one more question. Denise, I'm going to steer it your way. So how long of a process is the CDI/coder training? Did the entire team attend even if they were considered experienced?
Yes, the CDI education, the CDI team at UW Health all attended the education sessions, whether they had been in their role for a year or 5 years. So it was delivered to everyone, and everyone was expected to attend. And it depends on how long the education takes. At UW, we worked together as coding team, CDI team, to maintain some productivity because the CDI team was already established. We didn't want to pull the team down from productivity for whole days. So what we did was come up with a schedule of 2 hours per day for education, which still allowed them 3/4 of their work time to be productive and to continue their work, so that the hospital still got benefits from their work, even though we were providing education at the same time.
Thank you, Denise. And it looks like we're at time. So on behalf of Becker's, I would like to thank UW Health and Prism Healthcare Partners for their excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.